Good evening, and thank you for tuning in. This webinar format has definitely become popular in the last several weeks, and so I'm glad that we still have the ability to talk shop and learn from each other as dentists despite the need for social distancing. So tonight, our topic is radiation, with, of course, particular emphasis on where that fits in our role as dentists. So I hope after this discussion, you'll come away with some good information to consider next time you image your patients. So just a little bit about myself before we get started. I did attend dental school at the Medical University of South Carolina in Charleston, South Carolina. And then afterwards, I did a 3-year residency in oral and maxillofacial radiology at the University of North Carolina at Chapel Hill. And I am board certified oral radiologist. I'm a diplomate of the American Board of Oral and Maxillofacial Radiology. And at the present moment, I am in private practice oral radiology, as well as around once a month, I do still volunteer as an adjunct faculty at UNC, helping the oral radiology residents. And then here's my, my lovely wife of 11 years. Who is also a dentist. She's actually a pediatric dentist. And a big thank you to Plan Mecca for putting this event together. I think it's appropriate they're sponsoring this event in particular about dose, because they really are spearheading the effort to lower radiation dose with their imaging technologies. So I've held their imaging products, both the cone beam machines with their low dose capabilities and their Romexa software in very high regard before I started speaking for them. But they really have made a commitment to education, not only through this webinar right now, but also hosting a 2-day cone beam CT course at their facility in Chicago that touches not only on radiation dose, but also cone beam CT interpretation. And we'll briefly touch on that at the end of the presentation. So again, thank you to Plan Mecca. So the agenda for the evening. So first we'll go over sources of radiation, as well as their biological effects. Radiation risks. And then we'll spend a little bit of time comparing dose in dental imaging. So what we would typically use for 2D imaging in our practice, as well as cone beam CT. So we'll compare all of those together. And then we'll talk a little bit about what goes into the radiation dose for cone beam CT and what factors play a role in either increasing the dose or lowering the dose. And then we'll wrap up by talking about just a few imaging recommendations, both from the ADA as well as the NCRP. So first we'll talk about sources of radiation and their effects. And that is what radiation biology is. It's studying particulate and electromagnetic radiation, particularly ionizing radiation, on the living body. So particulate radiation, what we see here, is just one very large unstable atoms break down and release particles like alpha particles or beta particles. Those are used primarily in radiation therapy, radiotherapy, to treat either metastatic disease or some thyroid cancers. So for the purposes of this talk tonight and for us as dentists, we're primarily interested in this electromagnetic radiation. So that's what we'll be discussing. So here we could see several types of radiation that are on the electromagnetic spectrum. And so interestingly, for those of you who might have had an MRI in the past, that's a form of imaging that uses radiation in the form of radio waves. So MRIs do use radiation to form the image, but it does not use ionizing radiation. So as we move up the sources of radiation in this picture, the radiation sources start to have more energy, shorter wavelengths, and ultimately the two sources of radiation up at the top, gamma rays and X-rays, are ionizing. And so these are the two that we're primarily concerned with, and they are ionizing. And so for us as dentists, we use X-rays to image our patients. So what does it mean to ionize? It means that the radiation is able to remove electrons from atoms. So here we have an atom with a nucleus that has positively charged protons and, as well as neutrons. And orbiting this nucleus are electrons, which have a negative charge. So normally, these charges with the positive protons and the negative electrons cancel each other out when the electron's orbiting the nucleus. But X-rays have enough energy to displace electrons from their orbitals and ionize atoms. So ultimately, we have a positively charged atom here and a negatively charged electron. So that's what it means to ionize. So there are two different ways that ionizing radiation can act on our cells, our molecules. So the first one is through direct action. So this is when either the X-ray photon interacts with and ionizes our molecules directly, or an electron can also interact directly with our molecules. So with this example, with direct action, we'll see X radiation interact with this electron, which bumps it out of its orbital, and ultimately it's affecting the molecule of DNA over on the right side of your screen. And so that's causing damage in the form of breaks in the DNA structure because of that electron being removed from that atom. But also we have indirect action. And this is where the electron or photon interacts with a molecule of water, which then actually damages our molecules. So the X-ray removes the electron from its orbital, and the electron interacts with water. And so with the breakdown of water, there are free radicals that form. And it's these free radicals that ultimately cause damage to the DNA structure. And it's important to note that 2/3 of the damage that X-rays cause, the 2/3 of the biologic damage, is due to this indirect action. So it makes sense because, we as humans are, made up of primarily water, and 2/3 of the damage is caused by this radiolysis of water. So where the X-ray moves the electron to water, forming free radicals, which ultimately affect our DNA structure. And so many times our body is able to repair this damage to our DNA, but sometimes it can't, and these changes can become permanent. And these changes are passed down to later generations of cells. And so greater radiation doses, which cause damage to our DNA, would actually increase the frequency of these mutations. Now, some tissues are actually more sensitive to this type of damage than others. And so the law of Burgoni and Tribandot refers to this. So cells that are the most sensitive to radiation, the most radiosensitive, are those that are rapidly dividing, so they have a high mitotic rate. They're undifferentiated, so the cell is still primitive and has not yet formed into a specific type, like red blood cell, bone, muscle. And then those that have a long dividing future, so young, growing organs. And so this is one reason why when we think about radiation dose from dental x-rays, we are interested in knowing what's called the effective dose. Now this measurement, effective dose, estimates the risk of biologic damage and takes into account the type of radiation, so whether it's x-rays or gamma rays, as well as the radiosensitivity of the different tissues that are being irradiated. So we are concerned with effective dose, and this is measured in what are called sieverts. And we'll see sieverts referred to several times through this talk. So here we have just a few examples of cells, tissues, and organs that range from very high in their radiosensitivity all the way down to the least sensitive. So up at the top, we have examples of very highly radiosensitive organs. So these would be your very rapidly dividing cells or immature, undifferentiated cells. And as we move down each level, the cells or tissues become less sensitive to radiation. And so you'll notice actually at the bottom, you'll notice that mature bones, for example, are less sensitive to radiation than, say, growing bones in the intermediate section. So the mature bones have had time to grow, differentiate, whereas growing bones in a child would be more sensitive to radiation. So now let's talk about sources of where this radiation comes from. And it's important to point out that everyone on Earth is exposed to some amount of radiation every day. So just being alive, you're exposed to some sort of radiation right now. And so on an annual basis, for an average, the total annual effective dose of ionizing radiation to a person living in the US is around 6.2 millisieverts. So there's that unit, the sievert. We're exposed to around 6.2 millisieverts annually. And half of this comes from background sources of radiation. 48% of this comes from medical sources like x-rays. And then 2% comes from consumer products. So cigarettes being one, air travel would be another example. So let's talk about background sources of radiation. So radon is the largest contributor to background radiation. It's a decay product of uranium. It's a gas, and this can be an issue when it's products attached to dust, and we breathe that in, and it can stick to our lungs and cause lung cancer. So radon gas is actually the second leading cause of lung cancer, first being cigarettes. The second largest contributor to background radiation is actually from space, cosmic radiation. So cosmic radiation from space is the second highest contributor, although we are shielded partially by the Earth's magnetic field. So this is coming from the sun, from other stars, and this dose from space actually gets higher for humans as you go up in altitude. So like when we fly in a plane or live in a certain location. So an example I kind of refer to from time to time is Denver, Colorado. So Denver receives a space or cosmic ray dose around twice that of a location at sea level. Internal sources of radiation as well. So this is from the food that we eat. The food that we eat is also a source of radiation. So another example to use would be a banana. So bananas do emit radiation around 0.1 microsieverts of radiation. So the food that we eat does have some amount of radiation. And then lastly, we have other sources from the ground, terrestrial. So this is anything besides radon. So uranium, potassium, any sort of decay products that can give off some trace amounts of radiation. So all life on Earth is exposed to this background radiation. And so if we are exposed on average to around 3.1 millisieverts a year from background radiation, then that would equal around 8.5 microsieverts per day. And so this number, 8.5 microsieverts, will come into play a little bit later when we're talking about dose in dentistry. But again, we're exposed every day to around 8.5 microsieverts of radiation from background sources. So then the other half would be medical and consumer sources. And the clear winner here that takes up the most space is CT scans. So more than 62 million medical CT scans are taken per year, at least 4 million for children. That was a study that was done several years ago. So CT definitely is the main contributor for medical sources of radiation. Next, we have nuclear medicine. And so this is radiopharmaceuticals that are either taken by mouth or intravenously that are used to image patients. Interventional procedures, so image-guided surgery or like delivering a catheter. So this would be interventional radiology. Conventional radiology would be any other medical imaging that has not been described, like 2D images. And then 4% of this would be those consumer sources. So again, cigarettes, air travel, that sort of thing. But if you look closely, there's a little blank space at the top of this pie chart, and I'm about to fill it in right here, and that is dental. So dental is around 0.26% of annual dose, which is quite small despite the frequency that dental radiographs are being taken. But again, the dose in dentistry is much lower than in medicine. And so when looking at this data, I don't know about you, but the first thing that came to my mind was, okay, where does cone beam CT fit in this? And so the NCRP recently published new recommendations that we'll discuss towards the end of the presentation. But in their 2019 report, they say that the contribution to CT dose for a cone beam is presently unknown, but it is likely increasing. So next we'll talk about radiation risks. And we'll address the two major concerns that most everyone has, cancer and birth defects. So there's two kinds of effects. The main thing that is distinguishing these two categories is what's called a threshold dose. And so this is a dose level that must be reached in order for that effect to occur. And so here we have a stochastic, which this effect is like cancer. And stochastic effects, this is all about risk. We do not have a threshold dose. So there is no safe dose which does not cause cancer risk. So to put that another way, there is always a risk for cancer development at any exposure level. And the risk is proportional to the dose. So the probability of a stochastic effect can increase with dose. So a little bit of radiation has a little bit of risk of inducing a cancer. A lot of radiation has a greater risk of inducing a cancer. And next we have deterministic effects. So this would be like your in utero birth defect. And this has a threshold dose, which we'll touch on in just a minute here. So a threshold dose must be reached in order for an effect like this to occur. And with deterministic effects, the severity of the effect is proportional to the dose. So a higher dose would yield a more severe defect. A lower dose would yield a less severe defect. So in discussing cancer, if the smallest amount of radiation dose could cause cancer, what's the risk here? So the risk of cancer is not very well known at extremely low doses because most of the data we have about this is from atomic bomb survivors. But there's a committee that's published data about cancer incidence. And they are part of the US National Academy of Sciences. That's the Committee on the Biologic Effects of Ionizing Radiation. And they calculated that radiation-induced cancer incidence is around 10.8% per sievert. So again, there's that effective dose measurement. But in dentistry, the dose is very low compared to medical or other sources. So we as dentists are more in the microsievert range. And so if we take that 10.8% per sievert and we move the decimal over, we can see that it is 0.0000108% per microsievert for risk. But age matters. And this is why, especially for kids, we do want to keep the dose low because children are not little adults. Children are growing, their cells are dividing more rapidly, and they're more radiosensitive. So their cancer risk per unit of dose of ionizing radiation is higher. And they do have a longer lifetime risk of developing radiation-induced cancers. Not to mention, the thyroid is higher in the neck in children than in adults. So children may actually be 2 to 10 times more sensitive to radiation than adults. So that was talking about cancer, the stochastic effect. But what about in utero birth defects? I said there must be a dose that has to be reached in order to cause an in utero birth defect. And so that dose is in the range of 100 to 250 millisieverts. And there's a range there because of the timeline from pre-implantation of the embryo through fetal development. And so this 100 to 250 millisievert range, that's orders of magnitude above the fetal dose from dental radiographic exams. So 100 millisieverts, that's around 14,000 times more than the fetal dose from dental radiographic exams. And 250 to 300 millisieverts, that's around 42,000 times higher than fetal doses from dental radiographs. So ultimately, scattered dose to the developing baby, the fetus from dental radiographs, cannot produce in utero birth defects because the dental dose is very low. But again, we do want to keep the dose low for our patients because of the risk for developing cancer, because there is always a risk. So third, we're going to talk about comparing dose in dental imaging. And so this data comes from a study done several years ago comparing the effective dose of different dental imaging modalities. So first we come to the bite wing. So bite wing or PA, a set of bite wings would have 5 microsieverts of radiation. But again, if we think of it in terms of background dose, I find that's the best way to talk to patients about dose is by talking about background radiation. Background radiation is everywhere. Mrs. Jones, and it's always Mrs. Jones, right? Mrs. Jones, we're going to take these bite wings. This is around half a day of living on planet Earth. So a half a day of background radiation. Next, we come to the panoramic. So that is around 22 microsieverts, or 2.5 days of background radiation. A digital full mouth series would be around 171 microsieverts, or 20 days of background radiation. But with film, the dose is much higher. So we can see 388 microsieverts. And that is over a month of background radiation. So around 46 days. So again, when talking to patients, I find it easiest to talk to them in terms of background radiation. So what about cone beam? Where does cone beam fit in this picture? So we have to go over that cone beam really does vary widely. And you can have very low dose scans, but you can also have very high dose scans. So there's a wide range for cone beam CT, and there are several factors that go into that. And so here are a few of those factors. So number one, the dose depends on, of course, the particular machine or unit that you buy and the company that makes the machine, which makes sense. Different companies might use different reconstruction algorithms for generating the 3D data, or they might have other bells and whistles like having a low dose mode, like I mentioned at the beginning of the presentation for PlanMecca. They might even have a high definition mode for viewing very fine detail, like thin root fractures. So options like this they really widen the dose amount. So you can have very high or very low CBCT doses. Number two, the number of projection images. So as CBCTs or medical CTs spin around the patient's head, they are taking hundreds of images from different angles. And so each degree or angle, they might take a different image. So here's an example I have of an abdomen, a medical CT of an abdomen. And if we were to take a CT scan of this abdomen and only take 4 images, which you can see in the upper left box, we wouldn't really be able to see the abdomen at all. I just see some gray streaks in that window. But as we take more and more images, so 8, 16, 32, all the way up to 128, we can start to see the anatomy a little bit better. Our image quality seems to be improving, but again, the more images you take, the dose would theoretically increase as well. Third, what kind of field of view are you using? The field of view will dictate how much tissue is being irradiated, and ultimately that will affect your dose. So is it a large field of view? Is it a medium field of view? Or is it a small field of view? So all of these vary in their dose amounts. Number 4, region of interest. So that matters as well. Depending on the area of the maxillofacial region you're imaging, different anatomic structures are being exposed to radiation, and they all differ in their radiosensitivity. So if you're taking a scan of the mandible, your region of interest might include part of the thyroid gland or submandibular glands, for example, and those are more radiosensitive than the brain. And so because you were imaging or because the thyroid gland and the submandibular gland were in your field of view, that would affect your dose. So next is voxel size or resolution. So what is a voxel? If we think of digital cameras or the camera on our phones, the resolution is based on the number of pixels, right? So better cameras, the newest iPhone, they would pack in more pixels that are smaller. So more pixels that are smaller would have a better resolution. But the 3D version of a pixel that we use in cone beam is called a voxel. So smaller the voxel size, the higher the spatial resolution of the cone beam scan. This tends to come at a price though. So smaller voxel sizes can sometimes make the scan look noisy or grainy. So to overcome this, you may want to increase the amount of radiation so that you can have improved resolution but less noise. And that too would affect your dose. And so here's just an image to show you how different voxel sizes affect the resolution. So this is a cadaver mandible scanned at different voxel sizes from 400 microns on the left side of the screen all the way down to 100. And so you should see that the scans with smaller voxel sizes do look sharper or have a higher resolution than the ones with the larger voxel sizes. But again, the noise has been removed from this example. So to maintain image quality, if you take a scan with smaller voxel sizes, the radiation dose might need to be increased in order to have less noise. And so again, this would affect the dose as well. So what are the averages for cone beam CT across the industry? For a very comprehensive look, if you're watching, I would suggest reading this article that's at the bottom of your screen. This is a very comprehensive look at dose and cone beam CT, and it's a great article, especially if you're considering maybe purchasing one. If you have not yet purchased a cone beam CT, this is a great starting point. So this study was based on 167 different adult exposure combinations. And so they looked at large field of view first. And so for large field of view, you can see that the dose varies widely from 46 all the way up to over 1,000 microsieverts. But they found that the standard protocol average for cone beam, large field of view, was 212 microsieverts for large field of view. For medium field of view, the range was 9 to 560 microsieverts, and the standard protocol average for the medium field of view was around 177 microsieverts. So average dose from medium field of view of the maxilla and mandible is 177 microsieverts. Small field of view varies widely as well. So 5 microsieverts all the way up to 652. And the standard average for the small field of view is around 84 microsieverts. So now let's go back and compare the cone beam averages to the rest of dental imaging. So again, we've got our bite wing here, our pan, our digital FMX, and our film FMX. So there you can see the microsieverts, the effective dose, as well as the equivalent days of background radiation. So a small field of view cone beam scan is around 84 microsieverts. A medium field of view cone beam scan is around 177. And then here we see the large field of view at 212 microsieverts, or 24 or 25 days of background. And notice how all of these averages are still less than a film-based FMX, which is mind-blowing that the dose has come down that much. So hopefully you'll review that article, and if you already do have a cone beam machine and are curious to see how yours compares to the industry averages, I would reach out to the imaging manufacturer or sales rep and ask to see the dose information for your machine. And I think this would be a good idea too if you're looking to purchase a cone beam, if you have not purchased one yet. So just to kind of use this example for that exercise, here we're going to compare some Planmeca scans to the industry. So again, we have our small field of view, medium field of view, and large field of view for the industry. So these are the averages from that paper. And here we have small field of view on the normal setting with a Planmeca scanner. And that's equivalent to around 6.5 days of background radiation. And the resolution here was 200 microns. And so remember, I said voxel size matters as it relates to dose. And so smaller the voxel size, the larger the dose. So if you were to take a scan with a larger voxel size, this dose would actually be lower. And here we see the medium field of view scan. So 127 microsieverts, or 14.9 days of background radiation. And again, there's the resolution, 200 microns. And then large field of view, 135 microsieverts, or 15.8 days of background. And this was at 400 microns. But again, dose also matters as it relates to the company. So Planmeca does have an ultra-low dose imaging protocol that can be activated to lower the dose at the same voxel size. So here we see a small field of view scan, and the dose is 13 microsieverts, or just 1.5 days of background radiation. Medium field of view, if we were to take an ultra-low dose at 200 microns, would be around 30 microsieverts, or 3.5 days of background radiation. And then large field of view, 400 microns, ultra-low dose, would be around 34 microsieverts, or 4 days of background radiation. So again, if you look at the dose data from your particular manufacturer, you'll see that that the dose can vary based on the voxel size, but then also if your company does have different exposure options like high definition or low dose or ultra low dose, that can also change the radiation dose. And then lastly, here we will just go over imaging recommendations from the ADA as well as the NCRP. And so first up, we'll talk about the NCRP. So who are they? We've all heard about the ADA, but who's the NCRP? They're the National Council on Radiation Protection. So they're an independent organization, and they make recommendations on radiation protection based on scientific data. And so really the ADA makes their selection criteria recommendations based on what these guys say, the NCRP. And then it comes down to the local level where state dental boards make their own decisions based on what's decided by either the NCRP or the ADA. And so the NCRP periodically release a report that has all of their old findings, as well as any updates for both dental providers as well as the public. And the latest one was actually released in late 2019, and it is report number 177. And so here are just some of their recommendations. So first being, make sure to order radiographs after the clinical exam and review of the health history to determine how many or if radiographs should be acquired, which makes sense. We want to do our clinical exam first. And also obtain previous images when possible. You know, if the dentist had images taken at another office, because those previous images may be all you need. So you might not need to acquire anymore. And so, you know, that would eliminate radiation exposure to the patient. Or if the patient's previous dentist is monitoring for something radiographically, it would help you to obtain those radiographs and put the potential lesion or abnormality that they're following. They'll help you put it in context by comparing radiographs over time. So if you were to have those older radiographs and can compare to what you are taking in your office, then that might help ensure the proper diagnosis for that patient. And then next up, they do recommend, you know, going digital, using digital sensors. And so if you still are using film, if you go from a less sensitive speed of film like D speed film and you use F speed film, then that's already a 50% reduction of dose. And then if you use digital sensors, that's even a further reduction in dose. So they do suggest, having digital sensors for radiographs because it ultimately does lower dose to the patient. And then lastly, use rectangular collimation whenever possible. And so here's a image of what a rectangular collimator looks like at the bottom left. And so here's a representation of the surface area of round collimation. So this is what a majority of dental offices in the United States use. It's around 7 centimeters in diameter. But then here's the rectangular collimation, or just above the size of a size 2 receptor. So this rectangular collimated area is around 66% less than the area of the round collimation field. And so this reduction in size reduces the tissue area exposed to radiation, and that can actually lower the dose to the patient by anywhere from 45 to 95%. And a study by Dr. John Ludlow at UNC did find this to be the case. He found it around 80% dose reduction just by using rectangular collimation. And because you are collimating the beam to the size of the receptor, this results in less scatter radiation hitting the intraoral sensor, and this also helps improve the contrast of the image, so the image quality improves as well. And then lastly, we'll come to lead aprons and thyroid collars. So the NCRP says that lead aprons reduce exposure to the gonads. That's why we use lead aprons. But actually, with current technology, with the way the industry is going, these machines are putting out lower doses, and so nowadays with the gonadal dose from current technology, this is less than 5 microsieverts of radiation. So really, compared to using a lead apron, you would have a greater reduction of dose by using, digital sensors as well as rectangular collimation. And so you would have a greater reduction of dose if you did those things, as opposed to, just using a lead apron. And so the NCRP actually says the use of lead aprons is not mandatory if all other recommendations are rigorously followed, like digital sensors or using rectangular collimation. However, they also say unless it is required by state regulation. And so most states do require the use of lead aprons. So I'm in North Carolina. North Carolina does require lead aprons. Most states do. Thyroid collars. These reduce exposure to the thyroid, which is a radiosensitive organ. And so the NCRP suggests using the thyroid collar on children and adults when it will not obstruct your field of view or interfere with the exam. And again, as I alluded to earlier, the thyroid gland in children is higher in the neck than in adults. And so we do want to use the thyroid gland or the thyroid collar when we acquire intraoral images on kids. And then lastly, talking about CBCT. So the NCRP suggests for cone beam, you'd want to use the smallest field of view necessary for the diagnostic task, as well as exposure settings at the lowest possible dose appropriate for the diagnostic task. And you do not want to use cone beam CT just to reconstruct a panoramic or lateral cephalometric. So if you were to take a cone beam, there should be need clinically for the 3D data. And then lastly, they say that if you did not have experience with cone beam CT in dental school or residency, or if you're thinking about purchasing a cone beam CT machine, pursue some sort of cone beam CT continuing education. And so that's has been part of my role in partnering with Planmeca to offer a 2-day cone beam CT interpretation course. So if you're thinking about purchasing one, or if you have purchased one and have not taken a CE course, I would recommend taking some sort of continuing education on cone beam CT. And then lastly, talking about what the ADA recommends with cone beams. So the ADA Council on Scientific Affairs came out with an advisory statement in 2012, and it's a very quick read. And they summarize that 3D imaging can be used in lieu of 2D whenever you as the clinician, the dentist, think that 2D does not completely answer the diagnostic question. So if you need more info than 2D can provide in order to treat the patient, definitely that would warrant a CBCT scan. The entire scan does need to be evaluated in addition to your region of interest, and this needs to be documented in the patient's chart along with a report of any findings that you may see, whether or not it is in the region of interest. And thank you very much for your time, and I appreciate you tuning in to learn about radiation dosimetry. So I did receive a few questions during the session, and so I'd like to answer a few of them right now. So someone asked, how does a banana or food give you radiation? The example of the banana that I used, bananas do contain some amount of potassium that is, it can actually decay and emit some amount of radiation. That would be natural, but also food that we eat, that is canned, that is also irradiated as well. So if you were to eat organic, that might not be irradiated if you were to grow it in your backyard, for example. But if you were to get something from the store or in a can, it likely had been irradiated just to remove any contaminants. Someone asked, is the dosage for in utero birth defects cumulative, meaning patients who come in are getting minor microsieverts of radiation, but is a pregnant operator at risk for using it all day, every day? So the dosage for birth defects, that is cumulative. The occupational dose for healthcare workers is 50 millisieverts, and so that is very high. But again, the 100 to 250, that is above and beyond the occupational dose recommendation. So there would be very little chance of receiving that high of dose to induce an in utero birth defect. Someone asked, in taking digital bite wings on a child, what is a good way to explain to a concerned parent the background radiation of their child? We explain the diagnostic value for the dentist, but some parents are still hesitant or resistant to x-rays. I know exactly what you're talking about. My wife's a pediatric dentist, and she has to deal with that a lot too. So, number one, I think you're doing a good job in terms of explaining the diagnostic value, because the dentist can't treat the tooth unless they have a radiograph. In terms of explaining the comparable background amount, bite wings would be around 5 microsieverts. A pair of posterior bite wings would be around 5 microsieverts of radiation. So I would talk to them in terms of background radiation. So just around half a day of background exposure, living on planet Earth. Around, digital bite wings would be around half a day of background radiation. Someone asked the background radiation for PANS for 2.5 days. Was this digital or film? So this was actually both, because the dose for digital PANS is similar. It's a little less than film-based PANS, but film-based PANS actually use intensifying screens that convert X-rays to light, and then that light is used to help resolve the image. So actually, less radiation would be required, for obtaining a film-based PAN. So there is not much difference between a digital PAN or film, because film does use those intensifying screens. So I would just think of that 2.5 days for either one. Can I explain what is meant by taking x-rays after a clinical exam? The NCRP suggests that by just having the doctor doing an intraoral exam, just to make sure, based on the patient's restorations, number of restorations that they have, if a patient had, full mouth, rehab, restoration on every tooth, or if, the dentist could kind of tell that they were, caries prone, then that would, warrant imaging each tooth. And so the dentist would just want to do a clinical exam prior to just obtaining the radiographs. Also for kids, for kids, you wouldn't necessarily image or take bite wings until the teeth have erupted and the contacts are touching. So again, if you were to do a clinical exam and the teeth weren't fully erupted and there were, open proximal surfaces, the dentist could do a visual exam rather than acquiring bite wings. Someone said that their dentist might tell patients that lead aprons are no longer required. Is this information true? So again, this goes back to the state law. So I would check with the state dental board wherever you are located, and see what their stance is on lead apron use. Again, most states do recommend it. It's more for psychological comfort than is radiobiologically necessary, because the dose to the gonads is quite low, less than 5 microsieverts. But again, states still require it. So if you happen to be in a state that does not require it, then that's fantastic. But you want to make sure that you use digital radiographs as well as rectangular collimation. Based on the NCRP guidelines, you have to do everything else for you to not use a lead apron. So I would check with your state dental board. Someone asked, does the improved contrast apply equally to digital sensors? That's a great question. So this is less true for digital because you can go back and you can actually play around with the settings in your imaging software to adjust the brightness and contrast. So that is kind of a throwback to film, but again, ultimately you would end up with the ideal image if you were to collimate to the size 2 receptor. Someone asked, for a pregnant patient, is there a better trimester to take x-rays? So the developing baby, the developing fetus is most radiosensitive in the first 6 weeks. And then as time goes on, it's less and less. So in terms of, I guess, the better trimester to take x-rays based on your question, I would say, the later in pregnancy would be better. So babies are most prone or most sensitive during organogenesis, so developing their organs. Someone asked, if someone has a thyroidectomy, is it okay to take x-rays? Is there a special precaution? So if they had a thyroidectomy, either part or the entire thyroid has been removed. So I guess theoretically they would no longer have that organ and be radiosensitive in that particular area. But in terms of, is it okay to acquire radiographs? I would say yes, especially if there is a diagnostic need. So someone asked, what should their response be for patients when inquiring about using a thyroid collar for a digital pan? So with extraoral imaging and with pans, you just would want to make sure that that thyroid collar did not appear in the panoramic. So I guess this would kind of depend on patient size. So some people actually would not recommend using the thyroid collar for digital pans. So I would ask, or I would let the patient know that it's to protect their thyroid. But I would just want to make sure first that it did not appear in the pan. So if it does, then I wouldn't necessarily use the thyroid collar. I would just use the lead apron. But that's it for the questions. I think we're a couple minutes over. So thank you everyone for tuning in, and have a great evening.